Dear friends, I would like you to follow me, if you are not afraid of my English, in a series of discussions on macular edema and its surgical treatment. Let's see first a problem that is so common, the idiopathic epiretinal membrane. And I would like to start by asking this question, which is for me crucial, as I think that this idea of considering the epiretinal membrane as a disease inducing a visual loss has been, for many of us, responsible for misunderstanding on what is really a membrane. It is true that we often say to the patient, you have a visual loss due to an epiretinal membrane and we have to remove it, as we would say for a cataract. It is true that the metamorphopsia are due to the membrane contraction, and this is confirmed by the fact that they decrease immediately after surgery. But in no case the visual loss can be due to the presence of the membrane. We have all seen very thick membrane with superb reflections with 20/20 vision, and on the contrary, very thin membrane, barely visible in OCT with collapsed acuities. None of us can imagine that, as for a cataract, it is the physical opacity of the membrane that stops the progression of the photons, and the fact that the removal of the membrane does not allow an immediate restoration of the vision confirms that it is not the explanation for the visual loss. The membrane, therefore, appears more as a revealing process, a consequence, or an accompanying sign more or less important of a retinal pathological process at the origin of the visual loss. But then, what is commonly called an idiopathic epiretinal membrane? Certainly, as we have just seen, it is not a disease. It is a structure that we recognize either by OCT or thanks to the reflections it emits, reflections that are not proportional to the patient's function discomfort. When accompanied by the visual loss, this structure is always associated with an edema located in the outer layers of the retina. It seems, therefore, that it is rather the edema that is responsible for the visual loss. We'll talk about that later on. Other signs may be present, such as vascular tortuosity, retinal folds, or foveal ectopia, often related to metamorphopsia or pseudomacular hole. But this does not tell us what an idiopathic membrane is made of. And here I am obliged to remind you the work that I did in 1987 with my wife Yvette, who is pathologist. She published this work in the French Ophthalmic Society report directed by Jean O. At that time, I was already systematically removing the ILM, whose reflection I could see thanks to the slit lamp illumination of the operating microscope. In fact, I noticed that, doing so, I had much higher visual improvement than those mentioned in the literature. I sent her 56 specimens of membrane for analyzing using anti-collagen antibody type 1, 2, 3, and 4, anti-vimentine antibody, anti-protein 100 antibody, S100 antibody, anti-cytokeratin antibody, and anti-GFAP antibody. In all these 56 specimens, Yvette could find only 3 structures: acellular collagen II fibers corresponding to posterior haloid remnants, the hilum, a collagen IV acellular structure, and the gliosis. We are talking about gliosis when glial cells multiply and become fulfilled by microfilaments of GFAP. In the retina, there are mainly two kinds of glial cells. Astrocytes, which in a normal retina are in a quiescent state and connected to vessels below the hilum, and Müller cells, spread vertically from the hilum to the ELM. But contrary to what was admitted at the time, apart from rare yellow-cytes, inflammatory cells or RP cells exceptionally encountered, these glial cells were the only cellular contingent found. And it is important to say that in a normal retina, glial cells are not charged with GFAP. There is no gliosis. We then tried to make an anatomo-clinical correlation according to what we could remove, and were able to individualize two different scenarios. Either I could remove separately a preretinal structure and then, in a second step, the hilum. It was the case for this eye where a PVD was being done. The posterior haloid was stretched as a drum head and was sectioned to discover through the haloidal window the typical reflection of the glial proliferation that was dissected in a second time. The first structure exhibited the characteristic of a normal posterior haloid in scanning electron microscopy, such as in immunohistochemistry, GFAP negative and collagen II positive. The second structure was an hilum modified by glial proliferation, collagen II almost negative because some haloid fibers remain adherent, and GFAP positive. Either I could remove both structures at the same time. This was the case of this eye, where an attempt was made to create a plane of cleavage with a curved needle before separating the membrane with a foam hook and then removing it with a forceps. The specimens were analyzed. On one side of the specimen, the typical appearance of a normal posterior haloid was clearly identified, and on the other side of the same specimen, an internal limiting membrane modified by glial proliferation. Both collagen II and GFAP immunohistochemical specification were found because the two structures were so adherent that they came away together. The idiopathic membrane is not therefore a proliferative process made of cells foreign to the vitreoretinal interface, spreading over the retinal surface, but on the contrary, it is a structure composed of a mixture of posterior haloid and retinal gliosis in contact with the hilum. Confirmation can be given by Yvette's unique opportunity to examine an eye eviscerated for anterior segment problem that had an epiretinal membrane. In the standard HES staining, we see numerous cellular elements covering the retinal surface and giving the impression of a membrane composed of cells foreign from the retina. However, GFAP staining reveals that all this cell proliferation is composed exclusively of retinal gliosis coming from the inner layers of the retina. In fact, The glial proliferation, when it enters the hyoid fibers, changes the structure of their arrangement, which emits the reflection perceived by the observer, as happens when the corneal lamellae are swollen by an edema. The configuration and importance of the reflections that will be seen with the biomicroscope will therefore depend on the respective importance of the hyoid fiber and the glial proliferation. The more fiber and glial proliferation, the more reflective the membrane will be. In contrast, if there is no fiber and no glial proliferation, there will be an aspect of pure edema. In practice, several conditions of occurrence can be individualized. In a first configuration, there is no PVD when occurs the initiating stimulus of gliosis. The very dense reflections in this eye are related to an adherent posterior haloid that will be dissected with a curved needle. Taking off the haloid from the underlying tissue makes the reflection disappear. To avoid exert interaction at the vitreous base, it is decided to remove the haloid with a vitrectomy handpiece and limit its ablation only at the posterior pole. The injection of Kuma-C Brian blue that follows will allow us to see that the removal of the posterior haloid has caused a tear of the iLem. We start the peeling from this iLem flap and then we turn around the macula. Close to this configuration, we can include this case where there is a PVD but with a vitreous schisis. In this case, where the posterior haloid is eaten first with the prepapillary vein, the injection of Kuma-C Brian blue that follows allows to see that only a microscopic island of iLem is colored by the blue of Kuma-C. We tried to start the dissection from this small area, but unfortunately it is not large enough to allow it. And we confirm by the following dissection tests with the forceps that the rest of the posterior pole is well covered by the haloid fibers attached to the underlying astrocytic proliferation without a well-marked plan of cleavage. These cases are not the most common. In both cases, collagen fibers are very abundant. The glial proliferation is essentially astrocytic one, cross the iLem and proliferate under the posterior haloid, causing significant or even very important reflections depending on the intensity of this gliosis. In a second configuration, there is a PVD which leaves plaques of collagen fibers on the macula. These plaques can be single or scattered in small islands. These plaques, invaded by glial proliferation, show much more glare than adjacent areas. This is the situation most frequently encountered, I would say in about 2 cases out of 3. And this case is very interesting. It is clear that the Kumasi-Bryan blue has colored all the posterior pole except this haloid plaque, which appears in negative, with on its nasal edge a very colored collar, detached from the hilum, seat of an intense astrocytic proliferation on its external face. The haloid plaque, bordered by this glial proliferation, is detached without any particular difficulty, and the Kumasi-Bryan blue is re-injected to find out whether behind this plaque the hilum and the glial cells are present. Admittedly, the area of interest is less colored than the rest, which has received 2 successive colorations, but as can be proved during the dissection, the entire zone is well covered by an intact hilum in continuity with the adjacent one and mixed with the glial proliferation. We can distinguish a third rare situation, a variant of the previous one, but important to know in terms of surgery, where the glial proliferation is so strong that it extends well beyond the plaque centrifugally towards the temporal arcades, while covering the hilum. This was the case of this previously cited eye eviscerated for anterior segment problem, where it is clear that the retinal gliosis located just below the hilum crossed the hilum, spread under and on the adherent haloid plaque, and proliferated above the hilum centrifugally. This situation is important to know because the proliferation has the same coloring properties as the hilum one. This may induce the surgeon to think that the hilum has been removed when in reality only the parietal gliosis was taken off. It was the case for this patient where a first structure colored by Kumasi-Bryan blue and centered by a haloid plaque simulated the image that can be given by an hilum around a central plaque. In fact, a re-injection of Kumasi-Bryan blue shows that the hilum had not been removed and that the first membrane was indeed a preretinal plaque of astrocytic proliferation. The fourth situation is when the vitreous detachment has left very little or no fibers on the retinal surface. The gliosis will thus emit only very weak cellophane reflections, and we will have OCT and biomicroscopic aspect very similar to that of a macular edema. In fact, the difference between an idiopathic epiretinal membrane and a pure macular edema is the presence or the absence of adherent hyoid cortex. Here, except for small reflections we see towards the temporal vessels, and that will be removed at the same time during the hilum rhexis, nothing can separate this case from a pure macular edema. Finally, there is a clinical picture that must be evoked here, the vitreomacular traction syndrome, that everyone tries to identify as an isolated disease. although I cannot prove it. A simple explanation for me would be that glial proliferation penetrates the haloid fibers before the vitreous detachment is formed. There are then three possibilities. Either the traction exerted by the movements of the vitreous tear the haloid around the glial attachment. We then return to the situation number 2 of epiretinal membrane in plaque. This helps to explain why there are so many configurations in plaques. In fact, it seems unlikely that a normal PVD leaves macular plaques in 80% of the cases. Either the traction exerted by the movement of the vitreous tear off the vitreous plaque and the corresponding internal limiting membrane. And it would be in this case where we found this spontaneous healing traction syndrome with not only a cessation of the traction but also the visual improvement related to the removal of the ILM. Or the retinal grip of the haloid traction is strong and then a vitreomacular traction syndrome appears. Everything seems to be clearer now, but it remains to be understood on one hand, what is the stimulus that generates this glial proliferation, essentially astrocytic 1, which penetrates into the fibers of the haloid, and on the other hand, why the removal of the ILM is so beneficial in the visual recovery. This is what will be seen in the next chapter.